everybody. Welcome to our evening symposium, tonight's program, and a special welcome to all of our virtual attendees as well, who are watching via the Medscape Connect platform. We invite everyone to join the Medscape Live Connect platform by scanning the QR code, which hopefully will be showing on the front of the agenda at your seat. Joining this platform is your way to interact with us, which we hope that you'll do by putting in some questions. Don't wait until the end. Feel free to enter them as they come to mind. They'll populate our iPad and we'll have plenty of time to answer at the end. You'll also be able to follow along with the slides. So we encourage our virtual audience to ask questions as well. We'll get started. Our program tonight is entitled Rewriting the HCM Playbook, Contemporary and Future Treatments. So here's that QR code if you need it, and the password. And we'll get started. So I am Anjali Owens. I'm from the University of Pennsylvania, and I'm joined today by two colleagues and friends, starting first with Dr. Matthew Martinez. He is director of both the sports cardiology and HCM program at Morristown Medical Center. And next, Dr. Ahmad Masri, who is section head of cardiomyopathy and also director of two programs, HCM and amyloid, at Oregon Health and Science University. It's our pleasure to be here with you. So we're going to jump right in. First, we're going to take a historic look. So I think really to gain perspective on where we've come in this field, it's worth looking back to see where we started. Then we'll talk about myosin modulation, starting with a little bit of pathophysiology, mechanism of action. Then we'll turn to the meat of the program, which will be a dive into the clinical trial data that we have so far. And at the end, we have a few interesting cases that we will walk you through. So first, let's look back. What was the timeline of developing pharmacologic and invasive treatments for hypertrophic cardiomyopathy? Well, prior to 2023, the guideline was recommending pharmacologic therapies that relied upon fairly limited evidence base, starting with the beta blockers, then with the introduction of calcium channel blockers, then disopyramide. Now, along the way, we also had septal reduction therapy introduced. So let's start with the beta blocker class of medications. The first one that really emerged as a first-line therapy based on the astute clinical observations of really masterful clinicians that found this disease and described it. And, I don't know how Matt and Ahmad feel, but when we look back at some of those papers, it's really phenomenal. Amazing is a good word to put, how they sort of pieced it all together without echo, without the clinical tools that we have now. They were able to figure out what was wrong with these patients. And in the 1960s was the introduction of using beta adrenergic blockade as a way to help patients feel better. And again, this was based on empirical observation rather than controlled trials. And there was a landmark study done by giants in the field that actually showed that these patients felt better and that their chest pain symptoms were reduced. And after they were discharged from the hospital, they were continued on beta blockers. Now, the thought there, from a pathophysiology standpoint, was that you would reduce the heart rate, reduce contraction, decrease wall tension, that would result in benefit. And there were several beta blockers, they're listed here, that have been studied with HCM showing a similar class effect. Now, the one that you probably know the most is metoprolol, which sort of emerged as a beta-1 selective drug that we've used in HCM for a long time. Now, you'll notice on other outcomes that there are patients that have withdrawn these agents due to side effects or intolerance. And that's something to consider, right? Because you want to treat your patient with something that makes them feel better and not worse, and that they can tolerate this therapy because it may be a lifelong therapy. So this is the TEMPO trial. This is the first RCT evidence after 6 decades of clinical use. So after a long, long time, this was an interesting trial in that it was small, 29 patients, but a crossover design. And you can see here what they looked at: LVOT gradients at rest, peak, post-exercise, degree of exertional dyspnea and angina, and they also looked at peak VO2. And here are some of the results in terms of LVOT gradient, again, looking at rest and Valsalva, peak exercise, and post-exercise. Placebo here is in blue, and the metoprolol arm in red. And you can see that there was a reduction that they saw in LVOT gradient, and there was an improvement in terms of NYHA functional class. There was also an improvement in angina and in the KCCQ score overall summary score, a small change. So that became the mainstay of therapy. Then later in the 1970s to 80s, we saw that verapamil came onto the scene. So this is a non-dihydropyridine, so non-vasodilating calcium channel blocker. And I have pictured for you here some of the EKG changes that were seen in those very early descriptions, where they show the strain pattern resolving in a few patients on these agents. And on the right, I've shown the directionality of the systolic gradients that were measured in these patients. And it was sort of all over the map, but a lot of patients had some reduction in gradient, some did nothing, some actually went up. They also, interestingly, did coronary angiograms to show that there was improvement in the size of the coronaries with this. And again, they were looking at measures of diastolic function. They thought this would enhance relaxation. A lot of the same terms you're going to hear us talking about when we get to the newer therapies. They were doing the best with what they had. And so there was, a decision made to say, okay, based on the mechanism of action of beta blockers, what we've seen, the tolerability, that actually emerged as first-line pharmacologic therapy. And calcium blockers were used predominantly for patients who didn't tolerate the beta blocker medications. Next on the scene was disopyramide. Now, disopyramide, as you know, was developed initially as a class 1A antiarrhythmic agent, so not developed to target the underlying pathophysiology of HCM. None of these drugs were. But they saw maybe we could repurpose it because some of its properties could target the pathophysiology that we see in HCM. And the beautiful thing about HCM, I don't know how you guys feel about it, but there's every sort of cardiac pathology in a heart with HCM, right? You've got obstruction and hemodynamic derangements, you've got electrophysiologic derangements. It's truly, it runs the gamut of what you see in cardiology. And so they started using disopyramide. And the other thing I'll call your attention to is this is fairly high doses of disopyramide in order to get a negative inotropic effect. And this is data from Mark Sherritt, again, one of the giants in the HCM field, showing that they did see gradient reduction and that it was maintained in the study over 3 years or so. The biggest problem that they saw in terms of needing to discontinue the therapy was, one, some people became a bit tolerant to it, but two, is that they saw common adverse effects in terms of anticholinergic effects. And these can be quite bothersome, right? Because yes, we want you to be able to exercise and go up the stairs, but we also need you to be able to swallow and go to the bathroom. And so if you have a really dry mouth or you can't pee, that we haven't done you any favors. So the side effect profile can be limiting with this agent. And you do also have to be careful for conduction system disease. And so some people are a bit more hesitant to start this drug in patients that have conduction disease, QT issues. You have to be a bit more careful with it. So the next thing we'll talk about briefly is septal reduction therapy. This, of course, is the indication of invasive therapy coming onto the scene for obstructive HCM. And two main approaches that we use. There are now even novel ways to do septal reduction therapy. We don't have time to get into those yet, but we have surgical septal myectomy, alcohol septal ablation as the two main approaches. One, of course, is open heart surgery. The other is a catheter-based technique. And what's important to take home regarding these procedures is that, one, they are definitive procedures, specifically in the case of surgical septal myectomy, but it has to be done by someone who's an expert.
Really key. I think this is an important point to kind of hammer home. It's a really challenging surgery to do. Am I on?
You're on now.
Now I'm on, for sure. I think it's an important point. I think that this is a challenging surgery to do. It is not done in many centers already. And I think there's been papers published on this that the average cardiothoracic surgeon is doing 1 or 2 per year, which is way under what most of us would consider enough for expertise, which I would argue is probably over 50 a year before you have some real quality outcomes.
And the outcomes suffer when you have low volume centers or centers that don't have the experience needed. Unfortunately, a recent publication showed that still the vast majority of these procedures are done outside of the high volume centers. So this is not therapy that is accessible to all patients, at least right now. In terms of alcohol septal ablation, there is a higher percentage of people who have residual obstruction and may need a repeat procedure or a different procedure. So a little bit different when you're evaluating your patient for alcohol ablation in terms of complications of the procedure, including the risk for needing a pacemaker and the need potentially for a repeat procedure. So there are outcomes data that are published looking at what is the difference between these two procedures. I think the important take-home point here is that if you are treating patients with HCM at your center, you need to have a way to provide an opportunity for shared decision-making, a heart team approach that really shows patients what all of their options are when they're thinking about gradient reduction. So moving from septal reduction therapy to more a gradient reduction therapy, which now includes pharmacologic mechanisms.
And just because they want the alcohol ablation doesn't mean they qualify, right? Depends on what their ECG looks like, what's the coronary anatomy, does the artery, the first septal perforator, supply the area where the thickness is significant and the obstruction coincides to that area. So it's more than just can we, it's more than just do they want to, it's can we, does the anatomy fit the need?
How do you approach it, Ahmad, at your place? Do you have a heart team approach, a multidisciplinary meeting, or what do you do typically?
Yeah, I think one of the most important things is to actually tell the patients these things exist. Because I think one of the biggest things that the patient lose trust in you as a physician is that if you hide options from them, you don't actually have to go through each and every single one of them, but just inform them that there are these options. And we do see patients who come from other practices and say really, terrible things about the physicians because they just simply didn't mention that there are possibly other approaches. Now, to be honest though, we haven't reached out to alcohol septal ablation in a while now. The reason is that it's very unusual, at least in our practice, to have someone who doesn't want medical therapy or medical therapy is not enough and cannot get surgery. And so we're primarily a myectomy place. And so that drives a lot of that decision making.
Yeah, and I think you'll see that regionally, that there are geographies where you have an expert in alcohol ablation or you have more expertise in myectomy, and it's good to know that. And if you are referring your patient to a large center, be aware of what their strengths and weaknesses are, and that what your patient may be offered may depend on the center that they end up at. All right, we've reached polling question number 1, so hope you have your QR code there. How do you approach the sequence of pharmacologic management? Number 1, begin with a beta blocker, add or switch to a calcium channel blocker if symptoms persist. 2, initiate with a non-dihydropyridine calcium channel blocker, either verapamil or diltiazem straight away. 3, combine a beta blocker and a calcium channel blocker from the outset. 4, add disopyramide early in therapy to control obstruction. Or 5, consider initiating a myosin inhibitor before traditional negative inotropes. I'll give you a minute to answer the question. Here comes the game show music, I hope. Where's my music? No music. There we go. All right, not a lot, although votes are in. 70% begin with a beta blocker and then add or switch to a calcium channel blocker if symptoms persist. So this is an audience that's reading the guidelines. Good job, guideline followers. All right, let's move to the next section where we're going to talk about mechanism of action and new drugs that are coming and here.
Okay, so this was, you alluded to this earlier, and this is what excited me about hypertrophic cardiomyopathy as a career. When folks ask me about this is the exciting part. To me, the symptoms meet the pathophysiology, which then meets the treatment, and then, of course, the improvement in symptoms. So I'll remind you, a normal sarcomere looks like this, where there's actin and myosin interactions, where the MYBPC3, the myosin binding protein, is the molecular brake, and the force is produced from the motor, which is the MYH7 part of the myosin head. Those interact and provide normal contractility and effective relaxation as those actin-myosin interactions allow for that. And we often describe this as a set of rowers. So those rowers need to have enough rowers to produce contractility and force without being overly forceful, which is what we often see, which is what we see in the HCM patient. So if you go deeper and look at the actin monomer as it interacts with myosin, there is an enhanced interaction when there is a mutation. Increased contractility, impaired or slowed relaxation is shifted towards the active state. And this is the problem with HCM. There are too many rowers. So too many rowers lead to excessive force, increased contractility, the pressures rise, and as a result of that, all of the complications occur. In the untreated one, you get a left atrial enlargement, outflow tract obstruction, which we'll talk about in a minute, fibrosis or stiffness that occurs inside the LV, leading to diastolic dysfunction. The cavity ends up being smaller because of the hypertrophy, and that hypercontractile LV function is the norm when we start to think about contraction. So if any of you have children, if you've ever been canoeing, if you've been whitewater rafting with your children, it looks like this, where everyone's rowing, but we seem to be doing in a circle, right? So everyone's working hard, but we're all working against each other. So we have to say we all have to start rowing in the same direction. So this is what it looks like, a bit of a fight. And as a result of that, there is overworking of the ventricle, impaired relaxation, and you have increased myocardial energetics. I'm not an expert in this, so if any of you are molecular geneticists and know more about this, this is my version of it. But that to me is the take-home message for the HCM sarcomere interaction. Now, SAM, or systolic anterior motion of the mitral valve, is a complex interplay within HCM. So we think about hypertrophy as well as obstruction. Now, this is a disease of obstruction. The majority of patients with HCM will have obstruction, 60% or more, and that can occur in early systole, even into diastole a little bit, and it's related to the direction that comes with the change in flow related to that hypertrophy. So the septum and the basal septum in particular can direct flow towards an abnormal mitral leaflet, most often the anterior leaflet, and those alterations in flow dynamics lead to a push of the mitral valve leaflets into the outflow tract. With every contraction, with faster heart rates, with dehydration, you lead to more and more SAM with septal contact. Those leaflets are pushed more vigorously towards the septum, causing LVOT obstruction, and then mitral regurgitation in a posteriorly directed manner, all of the mechanism of systolic anterior motion. So we think about it in two pieces, right? If the heart is thicker, the left atrium gets abnormal, there's diastolic function and stiffness, as well as SAM with septal contact. And that comes because the leaflets are abnormal. It's part of the disease. So we usually think about this as hypertrophy, but abnormal longer leaflets, most often the anterior leaflet, but it can be both. It can be only the posterior leaflet, and that abnormal subvalvular apparatus, which I'm showing you on the right side with a very thickened papillary muscle leading to obstruction. Both a long leaflet and those abnormal papillary muscles are the mechanism for obstruction. So the leaflets are longer, they're apically displaced, they act like a sail as they sit into the LVOT, and they're pushed into the ventricle with contraction. So it's a complex mechanism that leads to obstruction and can happen in those who were initially non-obstructive. They can develop obstruction later on. So just because you're non-obstructive at one point doesn't mean you'll never be obstructive in the future. So most of the time this is being detected by 2D with color leading to the SAM and septal contact I'm showing you on the left side. These arrows show you that the long leaflet slapping up against that basal septum. And you can see, for the echocardiographers in the audience, you can see that callus that forms on the basal septum. So that area of echo bright on the basal septum is an indication that there's obstruction. So if you don't have obstruction at rest and you see that echo bright area, that's the SAM septal contact lesion. It's there, you just got to go find it. And it may not be present at rest in all, at least a third needs some sort of provocation to develop that. You can often see it on the short axis view as well. So posteriorly directed MR, LVOT obstruction from that SAM with septal contact leads to all of those sequelae we know about. So again, the pathophysiology of the treatment is then to specifically alter that. changing from the normal to the abnormal HCM sarcomere. There's too many engaged active myocytes, and the myosin inhibitors act specifically to lower that number. They're going to reversibly target the mechanism that leads to obstruction. And for the first time ever, this is a unique mechanism as opposed to beta blocker and calcium channel blocker. So this isn't just sort of a neat mechanism. It's the first time we've ever been able to do this in 60 years. This is a disruptive change in therapy, a paradigm shift in how we manage it. So whether it's mavacamten or aficamten, small molecule inhibitors, they bind directly to that mechanism and lead to changes. And removing the myosin head interaction normalizes the contractility of the heart, reduces LVOT obstruction, and improves the symptoms. So both drugs are going to act in a similar mechanism, although not identical. The aficamten actually binds to a different site, so it's not identical. But the outcome ends up being very, very similar, right? Works to stabilize to the relaxed state, diminishing obstruction as well as symptoms, improved exercise tolerance, and an increased quality of life. With either drug, the myosin inhibitors are a change in how we're approaching this. So this is the cartoon that I show the patients when we talk about this. Too many rowers in the HCM group, the myosin inhibitors come on and tell some of those rowers, don't row. And it leads them back to a normal state. And this is very helpful for them to start through what's happening when they're using this drug and reminding them that if the myosin inhibitors come off of those rowers, then it's going to go back to the way it was before. So you have the normal, you have the untreated HCM, and then the CMI-related obstructive on all the way on the end. And what you're doing is converting that untreated, where there's too many active myosin bridges, to a state that is similar to what the quote normal actin myosin relationship is. So with that, I'm going to turn this over to talk about the evidence for these unique drugs.
Great, thank you. I love this, the rowing cartoons that you have.
You're in Portland, so this fitness works for you too.
It's important, but not Morristown though. So.
No, we're not on the water, that's for sure.
Yeah.
But there's rowers near Penn.
Hey, that's right, we're rowing. You can come row with us.
All right, excellent. So we're going to talk about some of the clinical trial data, and we're going to have some discussion about each of these clinical trials. So there are a lot more clinical trials than the one we're presenting today. But, for the sake of time and discussion, we're focusing on the pivotal phase 3 trials that were conducted using cardiac myosin inhibitors. So the first phase 3 trial using mavacamten was Explorer HCM trial. Explorer enrolled about 50-60 patients, and we were randomized 1-to-1 to receive mavacamten or placebo. And the primary outcome was it's a combined outcome, so you have to think through this. It's not like something you can easily actually just like take away from the numbers. You have to either have a peak VO2 increase more than 1.5, while your NYHA class also increases by at least 1, or you have a peak VO2 increase above 3 and no worsening NYHA class. And the absolute difference was 20%. If you're used to looking at exercise studies, or if you're used to looking at outcomes trials in cardiology, you know that this is a very large effect size. And so the other important piece is that why do we treat patients with obstructive HCM? It's exactly what's shown here, is the fact that mavacamten, as presented by the blue line, versus placebo by the red line. You can see by 4 weeks, 6 weeks, 12 weeks, you have continuous reduction in the LVOT, resting and Valsalva gradients, as compared to placebo being stable around the same. And this was associated with lots of other secondary endpoints, from biomarkers to quality of life to different other things. And so I would pose to our esteemed panel here a question. In their opinion, what was the most practice-changing finding from Explorer HCM, and how did it redefine medical therapy for obstructive HCM?
Well, I think this was dramatic, and it completely changed how we manage the group medically. It also reminded me that the patients are engaged. So when this became approved, the patients brought it to me. We weren't sure we were organized yet. We weren't sure we had enough ready. It didn't matter. On day 2, I had a patient come in and say, here's the form, I need you to fill it out, I'm ready. I'm a chemist and I've been waiting for this. So I think it's changed the way we've delivered medical care. And honestly, in practice, it is overproducing compared to what I've seen in the trials. It seems to be better than expected.
Yeah. This was truly the oh my goodness moment, right? Yeah. This was the guys, we're cooking with gas. Like this works. And we knew it from the trial. We were blinded investigators in the trial, but required to do physical examinations. And in a half or so of the patients that were in the trial, we were like, I don't hear a murmur.
Yeah.
So this was a moment that was like aha,
And it was challenging
we're
during
onto something.
it was challenging during the study, right? Because you'd listen,
Oh,
and you knew
yeah.
there was no obstruction, and you were like, I think.
And, my coordinator started saying, Owens is keeping her stethoscope on for more than a minute. She's really looking for a murmur. So, it was an aha moment.
Agreed.
Yeah, and I agree. And the most important piece, I think, is the consistency of your ability to reproduce the finding, meaning this is not just a dynamic condition where one day there is obstruction, one another day there is not. You, by using mavacamten in this example, you had consistent reduction in LVOT gradient, which is really important.
Agreed.
So the second phase 3 trial for the mavacamten program was VALOR HCM, and VALOR tested a slightly different hypothesis, which is for patients who are being referred for septal reduction therapy, if they undergo randomization into mavacamten versus placebo, can we actually prevent them from asking to undergo septal reduction therapy? Which, if you've seen the results from the previous trial, you would guess the answer is yes. And that's exactly what was found, is that in the mavacamten arm, you have the guideline eligible for SRT was only 18% versus 82%, meaning that by using mavacamten, you could prevent patients from requiring septal reduction therapy. And I'm showing you the long-term outcomes in terms of the LVOT gradients here as well, showing you again what you've known already, that you're reducing LVOT gradient. Just a reminder that the need for septal reduction therapy stems from two things. You have symptoms that are perceived as burdensome despite first-line medical therapy, and then the second, or you can't tolerate them. And the second piece is that you have a peak LVOT gradient above 50. And so if you modify any of these, obviously you can, then remove that eligibility for septal reduction therapy. And so in terms of mavacamten safety, and I thought we had a question here, but we can keep going. In terms of mavacamten safety, this relies into the rest of it. So what we've shown you so far is that there is an effective drug. I don't think there's a lot of debate there about a drug being effective. And when the drug is effective, you need to learn how to speak to patients about it. But then you need also to learn about what is the important things to think about as I talk to my patients about that drug. And with mavacamten, because it's a negative inotrope that is very effective, but at the same time, it has a risk of reduction in LVEF. So LVEF falling to less than 50%, someone essentially has an EF of 48%, they're completely asymptomatic. That is really not the same as someone having heart failure. And I think that's where it took a while for people to try and understand the difference between the two. And if you use that metric, left ventricular ejection fraction less than 50% as your metric, you realize that in the Explorer HCM trial, you've had an average of 5 to 6% of patients on mavacamten achieving that point. Now, I want to point out something, that Explorer was the first phase 3 trial. So we didn't know a lot back then. So that's almost, you had to design this back almost 8 years ago or something along these lines, even more. And so in the trial, the levels of the drug were used to monitor patients. And it's important to highlight that there were significant number of patients who underwent down titration of the drug because of their levels being high, even if they had no other issues going on with them. I'll tie this back to the commercial use of the drug later on in a different slide. In VALOR HCM, there was no monitoring of the drug level. These patients were guideline eligible for SRT, so you could argue maybe they were different patients. But if you put the table 1 for both trials next to each other, they actually look somewhat the same in terms of the burden of the disease, except they were more symptomatic. But their NT, proBNP, other things look the same. And this trial allowed us to think through, okay, how can you use mavacamten? How can you do it if you don't have drug monitoring? And it showed us the outcome out to 128 days. The placebo randomized portion was 16 days, but the total trial duration was 128 weeks. 16 weeks, 128 weeks. And so that essentially is an important metric, because then you can realize if you're aggressively titrating mavacamten like they did in the trial, what would be the outcome? And the outcome was that they had EF less than 50% in 14% of their patients, including, you know, 1 or 2 patients who had EF, you know, much lower and had symptoms and all that stuff. And so here is one of our questions. How did Valor HCM change your perspective on when to refer patients for septal reduction therapy?
Sure. It became a conversation, is what I'll say. You know, it moved from you need surgery, your left atrium is getting larger and larger, you have pulmonary hypertension, you're class 3, your resting gradient's very high. We know where this train is heading. It's time to really do this. To a conversation of there may be another option for you. It's based on a relatively small trial, but they were the right patients, at least at our center, that we put in that were already on combination therapy, somebody already on disopyramide, where we would say there's one other option if you choose to take it. And at any point, you could make a fork in the road and say, nope, this isn't working, and pivot over to septal reduction therapy. But it became an option.
Yeah, and the Valor group was sicker, as you alluded to. In the Explorer group, it was mostly class 2s. In the Valor group, it was mostly class 3s. And what often gets misrepresented is that this means that it's better than surgery. And that's not what it means. What it means is that in those who are headed to surgery, you can start the drug, and then they may not qualify for it in terms of symptoms of LVOT gradient. We don't have a head-to-head, and we may never have a head-to-head, but it is another opportunity to treat patients. And I think the paradigm shift for medical treatment now with Valor and with Explorer had changed, because now we were treating people earlier. No one was operating on somebody who was class 2. If you were intermittently symptomatic at 4 blocks, most people were not going to surgery. They were sicker. So I think that was the take-home message for me, that in that group that was sicker, I had an opportunity to treat folks. And then in some patients who I weren't sure if they were going to get a bit better with surgery, maybe this was an opportunity to see how much they would improve in terms of symptoms, and then revisit whether or not they need surgery or not. So it's not an or, like you don't have to choose a fork in the road never to come back. It may be a way to decide who needs something else later on if they choose to. But I agree, totally, it brings on a conversation that we've never been able to have before.
And options are good, right? When you're dealing with patients that vary in their opinions, they vary in their circumstances, they vary in their preferences, it's always better to have more options.
Absolutely.
Than fewer.
Agreed. And you allude to this in other talks that I've seen you actually present, where you showed what happened to the individual patients who underwent septal reduction therapy. And there were a lot of different outcomes in these patients and adverse events. So when you study something in a medical trial, in a clinical trial, you actually have to report everything as an adverse event or serious adverse events that happen. While if you're just doing observational studies and a patient has some kidney injury or needs intermittent dialysis, you're like, that's fine, it's just after surgery.
True.
And that essentially trial showed that once you start reporting everything, you're going to find so many things that happen post-septal reduction therapy. So shifting gears a little bit, so mavacamten got approved by the FDA and now in many, many other places for the treatment of symptomatic obstructive hypertrophic cardiomyopathy. That's defined by having NYHA class 2 and 3, while you have a peak LVOT gradient above 50. And so, and again, based on the guidelines and traditional practice, it's thought to be second-line therapy after you have tried beta blockers or calcium channel blockers or combination of that. And so, but mavacamten was approved with something called the REMS program, which is a risk mitigation strategy by the FDA. Outside of the United States, the same REMS program is being used in a way as a, to give direction on how to use the drug. And some in Europe, for example, they require you to do genotyping of the liver enzymes to make sure that the metabolizing status is not, poor and whatnot, and they have different rules for that. So if you're interested, go back and read more about this. But in the US, we have the REMS program, and the REMS program, after discussion with the sponsor, they didn't use drug levels to monitor the drug, but they used instead echocardiography. And so when you initiate mavacamten, of course, there were multiple iterations. I'm going to just talk about the most recent one. When you use mavacamten, you have to do 3 echocardiograms in the first 3 months at a fixed dose of either 5 milligrams or lower. You can't uptitrate in the first 3 months. And they use a Valsalva LVOT gradient less than 20 as trying to flag what's called the super responder group, but you don't necessarily always have to follow that. There are some nuances there. And then after that, if the patient is stable, then you need 2 echoes a year. If the patient requires up titration of the drug, you have always to do another echo, and it follows a cycle of 12 weeks. Every 12 weeks, you cannot increase mavacamten more than once every 12 weeks. So that's the cycle that it follows. Every time the patient calls you, I feel short of breath, I have leg swelling, I'm unhappy in life, you need to essentially make sure you evaluate them so that they're not actually having an adverse outcome there. A common scenario is atrial fibrillation, and we can talk about it later with the panel here. So then fast forward a few years, we have some real world REMS program data. I'm not gonna delve into this. I'm just gonna mention that there are lots of data out there you can refer to. But I was gonna one thing about the REMS program is that there is no obligation to report the adverse outcomes. And so this is your classical survival bias, reporting bias in different things. And so I would encourage everyone to think about real world use and to think about clinical trial data more than the REMS data, because the REMS data don't allow us to understand what happens to the patient when their EF is less than 50%. Because if they get taken off the drug, you actually don't see that patient again in your database. So just keep that in mind. So we've done a little bit of work on this. This is a study of 2,400 patients. This is claims data, so we don't have access to their echocardiograms, but we had access to all of their medications and all of their claims. And what you see here, it's a single group because there is no contemporary control group for mavacamten. And I resisted, even though we get pushed a lot by the reviewers, to synthesize a control group. There's not. I mean, we cannot just make up a group that will be biased. And so you can use this as a single observational group just to understand healthcare utilization and what's going on. And we used new heart failure, new AFib, new flutter, and then some other endpoints to see what's going on. Now, this doesn't say anything about mavacamten as a drug that it leads to any of that stuff. That's not the goal here. The goal is to show that there continues to be ongoing use of different parts of the medical and healthcare system, and we should continue to study the performance of these drugs in the real world. That really is the message out of this study there.
Yeah, and I think it's a reminder that the disease is still ongoing. You may have removed symptoms, but the disease has all of this stuff: atrial flutter, risk for TIA and stroke, and heart failure. And because you relieve the obstruction, you didn't take away their obesity, their hypertension, their diabetes. So the rest of their clinical story still moves on. And I think you have to take all of that, as you say, not necessarily causative from MAVA, or it could be, but this doesn't indicate that.
Yeah, I think, one thing we presented just in abstract form, I guess it was yesterday, the days are running together, a smaller number of patients, 500 or so, looking at claims-based data prior to index date, which was start of mavacamten, and after index date. And the follow-up was relatively short and claims-based data, 8 months or so. But what we did see was a decrease in the number of hospitalizations and ER visits. And that's, again, comparing one individual to themselves before and after starting MAVA. Now, we need a deeper dive, right, to look and see what happened with AFib, what happened with all those other outcomes, heart failure, et cetera. But I think it's encouraging that there was a decrease in those. And a control group would be amazing, but let's face it, we're in the real world. And I think we do the best with the data that we have.
Yeah, and that's not a surprise, correct? If you have someone who is is symptomatic, obstructive, and you put them on mavacamten and they respond nicely to it, there is no surprise that they're going to do
better.
That's
better.
Right. Yeah.
There's no surprise at all. I think this is more or less a call to action in a way that we can't stop at the clinical trial evidence only, because we need to continue to generate more data, because ultimately, let's face it, in our clinical trials, we dose anywhere between 200, like if you look at the active group, it's anywhere between 120 patients only to 250 in the non-obstructive trials. So that's a small number of patients after all. And I use always the amyloid. I use an example from tafamidis, a track trial in amyloid, where the number of patients who were dosed with 80 milligrams of tafamidis was below 200 patients. Yeah. The number of commercially dosed patients in the United States on tafamidis are more than 30,000. And so when I say tafamidis doesn't cause, for example, any side effects, I'm referring to the 200 or less patients dosed in a clinical trial, while you have 10, 20, 30 times more cells. So that's in a way to tell people there is a disease that is still ongoing. These patients have issues, have problems, have high healthcare utilization. And if you look at the new prescriptions for these patients, which to me, actually, I see them as really good surrogate of what's going on for these patients. You had 4% of them needing a new oral anticoagulant, 6% taking a new loop diuretic, and then about 4% requiring a new antiarrhythmic. So your job is not done just only by relieving LVOT obstruction. The disease continues to go for a fraction of these patients, not everybody, obviously. It's a small number, but still there. And so then we wanted to take it a little bit further because, MAVA LTE had a very interesting observation, which again, you cannot really confirm any of it. But MAVA LTE had an interesting observation is that there was some atrial fibrillation on mavacamten longer term. And that rate was maybe slightly higher than we are used to, but these patients were also sick and being monitored frequently. And so we've asked the question, can we actually look at a large number of patients in the real world, not using claims data, but instead asking everybody, what have you seen in your practice when it comes to ejection fraction, symptomatic heart failure, cardiogenic shock, and atrial fibrillation? And so here what we're showing you, these were about 22 centers that contributed data up to 1,500, 1,600 patients. This is exactly why you can't rely on single center data. See the variability in the rate of adverse events by center. You go all the way from 3 events in 100 to some centers having a much, much higher rate of events. It averages out down to 8%, obviously, but it goes all the way in some in the double digits and some in the single digits. And so that's why you need multi-center evaluations when you think about these things. And we've shown that 8% had EF less than 50%, which is, I think, what you would expect overall in general, 1.5% symptomatic heart failure, and then 0.5% or less cardiogenic shock. All right, before I go into here, any comments if you would like to say anything?
No.
All right, excellent. So now we're going to shift gears about 2 other trials that were done in obstructive hypertrophic cardiomyopathy, symptomatic. A reminder that aficamten is not approved yet in the United States by the FDA. So Sequoia was a trial of 280 patients with obstructive symptomatic HCM, and the primary endpoint was peak VO2. And as you can see here, placebo flat and aficamten led to an increase by about 1.7, 1.8 ml per kilogram per minute in peak VO2. There was a whole host of other secondary endpoints as well as a pre-specified endpoint for NYHA class and peak VO2, biomarkers, quality of life, echocardiography, and all of the rest that we've spoke about before. Here you can see how the gradient went down rapidly as well in the first 8 weeks with titration, and you can see also the rest of the clinical outcomes there, as you'd expect them to be. Now, quickly on safety, touching there, this was an integrated safety analysis. The first table is from Sequoia itself for the patients who had an EF less than 50%. And the second portion is from an integrated safety analysis looking at different pooled and rates of this happening from the long-term extension as well as from the trials. And that showed that if you look at all the patients up to that date that have been dosed with aficamten, the rate of LVF less than 50% was 4.1%, and the rate with clinical heart failure was 0.6%. And, we can talk about this later, but there's like a core lab evaluation and a site evaluation, and they're not always congruent there. And so a question here is, what are the key results from Sequoia that expanded your confidence in aficamten as a disease-modifying therapy?
I think it's additive. I think it was additive to what my thoughts were about mavacamten. As I mentioned earlier, mechanism is very similar but not identical. And I think in both the studies from mavacamten and now again from aficamten, reassuring that we saw a decrease in left atrial volume, we saw a decrease in wall thickness, decrease in the objective BMP across the board. So I found it to be, again, reassuring that this is a true mechanism in relieving not only the obstruction and the symptoms, but seeing some actual structural changes that I think for drug therapy, we've not seen too much before with HCM. Do you agree?
Agreed. And I think the key there that you're asking us is the disease modifying effect, right? And if, to me, the sub-study done by MRI of the Sequoia trial really hammered home that the structural changes are meaningful and that long-term they may result in changing the natural history of this disease, which is ultimately what we're after. Can we put you on a drug that will take you away from a path of developing AFib, having a risk of a stroke, developing the risk of heart failure, to a path of stability and improve quality of life, all those great things, but avoidance of the complications. And I think this really built upon that, particularly the MRI data I thought was very intriguing. The other thing is this on a cellular level, looking at fibrosis? We didn't see any change in replacement fibrosis. And, I'm talking to an imager here and I'm a heart failure chick, so I'll defer to you on what it showed on a cellular level. But to me, those were intriguing changes, where there's some changes on a cellular level that tell us that this may prevent progression of fibrosis. And we know fibrosis leads to bad things in this disease, in all diseases. So that to me was intriguing.
Yeah, so we all talked about how we're trying to not just forget that there's other things that happen, atrial fibrillation as an example. So if you're seeing left LAVI go down, you're seeing LV pressures go down, diastology is improving, BNP is coming down, it's no surprise that we're seeing some of those benefits in sequelae. And what I loved about the stabilization of fibrosis is that it brought to mind, well, those were folks who had fibrosis, they didn't get worse. What if we started it before they had fibrosis, right? Would it actually prevent it? And we don't know that, but it does beg the question as to whether or not we can actually prevent it.
Absolutely.
And prevent folks from heading towards the heart failure route and then needing advanced heart failure therapies.
Yeah, and I think we can get, it has to be, I know it's observational data are biased, but eventually we'll get to that. There is, now we have actually a very sizable cohort of serial CMRs that are gonna go up to 5 years in the Forest HCM study. And ultimately, to answer that question, we need to find a really well done observational study for the natural history of progression of HCM pre-CMIs, essentially, to maybe answer that question. But I think that's the point, is that eventually we'll have to, if we want to progress in our understanding of this, we have to marry different approaches in understanding this disease process. So I want to spend a little bit of time talking about something new that probably a lot of you have heard about, but if you haven't, that's the purpose. This is a trial that only reported less than 2 months ago, or something along these lines, maybe a little bit more than 2 months ago. Maple HCM was, in my opinion, and I'm a little bit biased because I was part of the study, but it was a bold move where you would take a drug that is thought to be a second-line therapy, and you essentially bet it against the first-line established therapy. And we've heard from Dr. Owens how long this has been the practice. You're talking about practice of 60 plus years. And so Maple HCM was aficamten versus metoprolol. This was a double-dummy trial where you take into account the patient heart rate, blood pressure, symptoms, which is they had to be symptomatic. They couldn't have previous history of intolerance to beta blockers. They could be naive, not been on beta blockers before. They need to wash out if they were on beta blockers. And then you would start them and randomize them into aficamten versus metoprolol, but there is also a placebo portion of it so that the patients cannot guess what they were on, and I can't guess what they were on. And so this is pretty complicated design, but it was executed and executed well. And you go through it like you did with Sequoia, which is up titration in the first 6 weeks as needed. There is some guidance to how this can happen automatically. And then the primary endpoint was peak VO2. And I think, without seeing the results, you would have guessed what aficamten would do, because we already have seen from Sequoia that aficamten increased peak VO2 by an X amount. In this scenario, these patients were slightly less sick and had less a burden of disease maybe, and so they had still a significant increase in their peak VO2. But I think what is the important takeaway from this trial as well is that metoprolol led to a reduction in exercise capacity as measured by peak VO2, and not just peak VO2. Greg Lewis did a great job presenting this a few weeks ago at the Heart Failure Society of America meeting and showed that on all exercise metrics that he can think of, and he brought new ones as well over the last year, all of them headed in the same direction. And so it's not just about peak exertion, it's also about submaximal exertion that gets affected by metoprolol as well in that patient population. On top of that, we had no significant effect on LVOT gradients. And this might have been one of the biggest findings of the study. Now, then people started talking, well, you don't use metoprolol to lower the gradients. You use it to make people feel better. Like, okay, that sounds okay. But why would you use something that makes people feel better without affecting gradients and while making the exercise capacity worse? And so that's what you see here, where aficamten lowered LVOT gradients at rest and Valsalva, while metoprolol did not. Now, the dose range of metoprolol was 50 to 200 milligrams. The dose range of aficamten was 5 to 20 milligrams. And as I mentioned, there were automatic rules for titration of metoprolol. And the goal here is to test the clinically relevant, widely used doses of metoprolol in a clinical trial. Because if you stopped at 50 milligrams of metoprolol, the first thing anyone would say, you didn't dose metoprolol adequately enough. And if you put everybody on 200 plus of metoprolol, everybody was going to say you overdosed everyone. So there were rules and there was a range, and you're going to get to hear more about this in subsequent conferences and symposium. So what happened as well? And I would argue these are extremely important findings from MAPLE. One is that NT-proBNP, which is a measure of stretch inside the heart and wall stress as well, and has been shown over and over to correlate with outcomes of these patients and severity of disease, did go up with metoprolol. And you can see in the initial 6 weeks of up titration, it continued to go up and then, stabilized a little bit over time, while with aficamten, essentially almost near normalized there. Another finding in the left atrial volume index actually went up as well on metoprolol compared to going down on aficamten. Another important finding is that when you put drugs to the test, you actually truly find out what's going on with these medications. And so with aficamten, you had a few patients that underwent dose titration. The exact number was 4. The core lab confirmed EF less than 50% in one patient. And if I recall, it was an asymptomatic EF less than 50%. And then the mean reduction in EF was 5%. And one patient had to actually interrupt the drug on aficamten. Now compare that to metoprolol, where you had about 30% of the patients required down titration of metoprolol using certain rules or how they felt essentially. And the reduction in EF was 0.5%. And then there were no events of EF less than 50%. And so this is an example, like we talked about in VALOR. Once you put something that everybody uses to the test, you start to find things that you actually have not necessarily thought of before, which is really important in terms of the drug therapy that we use. So I know I spoke for quite some time about MAPLE and the results. How do you think about that? And how do you think about MAPLE when it comes to first line versus add-on therapy in terms of aficamten?
So a super important study, as you point out, because it brings us to a whole new discussion. What it brought up for me, as you mentioned, that many of the patients were on beta blocker. So about 75% were on beta blocker and obviously still having symptoms, and then were titrated off. We had about 6 or 8 folks in this study. So when you remove that, then you're adding on another drug. But I took home 2 pieces. One, I haven't titrated somebody over 100 of metoprolol in a long, long time. And the peak doses were high, 175 or 200. But that's definitely what's happening in practice. people are being referred to me, and you, I'm sure, with 200. I think my record is 400.
Oh.
Impressive. The patient was less than happy with that. So we titrated that off, number one. But mostly it showed me that this drug is safe to take by itself. And I think that's important. I think more has to be done to really kind of dive into this data, but it made me feel better about a practice we're often doing. We're titrating down folks off of a beta blocker onto CMI therapy alone, MAVA now, but now AFI going forward. So it showed me this is safe to do. And for me, that was the changing part.
Yeah, this gave me pause, right? So when you look at those curves and you think, wow, there's no drop in gradient here. And then I look back at tempo and I was like, well, there was a drop there. Like, what is this? So it definitely gives me pause. And I can't say I can wrap my head exactly around the findings, but it does tell you that you need to do randomized controlled trials. And whatever therapy you're going to use in your patients, study it and understand it so that we don't go for years using things that we're convincing ourselves work and our patients, right? I don't remember if you showed the KCCQ, but the KCCQ even went up.
Yeah.
And you're thinking, my goodness, your KCCQ went up by 8. And there's your peak VO2 and your gradient didn't change and your NT-pro's worse. So it definitely gave me pause. And I think we needed to know that. It also highlights the complexity of dosing in a clinical trial. You don't want to be the criticism that you didn't dose enough metoprolol, right? Just as you said, that would have been a high criticism if the dose wasn't pushed. But now we're in a situation where I think we do wonder, did some people get to a really high dose and they didn't tolerate it? Was it that we titrated too fast? You know, it's not my typical practice to go up every 2 weeks on beta blocker, but we're coddling people and calling and saying, take it at night. And yes, I know you're fatigued. You know, we do a lot of hand holding in the real world that it's just not practical in a real trial. So I think we had to do it. We did it. And now we see the findings.
And two other, I love that you said it gave me pause because I had the same thought. I think we all anticipated this, that in our practice, we assumed that patients would get worse with beta blocker, and we showed that. I was surprised that peak VO2 on aficamten wasn't higher. I would have expected it to be 1.5 or above just with aficamten alone. So I want to better understand that.
I think that's probably a feature of a little less sick population. If you look at their gradients, you look at their baseline NT-proBNP, they didn't have the same requirement for low peak VO2, less than X%.
Fair enough. And then you and I have talked about this. I have patients who get better on a low dose of a beta blocker, 25 or 50, they feel better. Their gradients stay high, to your point, but I make them go on a treadmill. I put them on the table of truth and they do really well. And they say, see, I told you I felt fine. What I don't know is that okay? Leaving somebody with obstruction despite a normal treadmill study or normal symptoms, are we okay with that? We used to be because our only option was surgery. So now that we have this moving forward, I want to know, should we be treating that group? If you look at some share registry, I'll have to explain this to you, they do worse.
Absolutely.
If you're class 1 and your obstruction is there, they do worse. So I think it opens this avenue to, should we be treating folks, forget about the symptoms, man. Should we be treating the LVOT obstruction? Talk about a paradigm shift.
Yeah.
Agreed. And you know, I'm gonna spend the next 6 months convincing you that this is probably not a dose-related phenomenon.
It may take 6 months for me to wrap my head around it, but I'm willing to listen.
That's my homework.
A heart failure doc. It's okay.
You know, and I find myself
homework.
asking, like, should I get all my metoprolol patients and trend back their NT-pros and look and see what happened? You know, it really makes you wonder, like, what have we been doing?
Yeah, I know. And, you know, but I would go back to the multi-center concept there, is that the reason to do large multi-center trials is that the variability, the intrinsic variability gets reduced in single center settings because you have a very specific practice. You do things in a certain way, but that's not how we evaluate the drugs themselves.
Right.
And so if we want to be fair, we have to evaluate everything the same way, which is how we ended up with the MAPLE results. So let's see here what we have. Now, I don't know how if we're good on time or not, but maybe we'll jump quickly through this because I think this was important update from ESC. So Odyssey, which is mavacamten in non-obstructive HCM. This is the natural progression. You want to study the drug in obstructive HCM and then in a non-obstructive HCM. This was built on the backbone of Maverick HCM, a phase 2 trial that was done previously. And Odyssey, resulted in a surprise finding that there was no significant difference in quality of life as measured by KCCQ or in peak VO2. Now, there was small change in peak VO2 that, in general, you don't see from placebo. So there was evidence that there is something kicking in there. It's not like totally, completely, it's flat line. With KCCQ, the surprise was that your placebo group with KCCQ did extremely well. And so that was another surprise there. To me, actually, one of the biggest surprises is the one on the right there. The fact that NYHA class difference was only, improvement by one NYHA class difference was only 5%. I would have expected that number to be 10, 15%, even if the study was negative. So that was a slight surprise for me there. And so safety was part of the story of, I don't think you can talk about Odyssey without putting that into context of how did the patients do on the drug. 290 patients were on mavacamten, 290 were on placebo. And if you look at the adverse events of EF less than 50%, 22% on mavacamten had that. In the protocol, they had to actually stop the drug and restart later at a lower dose. And also, patients had multiple opportunities to up-titrate. Some of them were closer to the end of the study. Whether that interfered or not, I think we're going to find out a lot more. This was only the primary presentation. There were a few presentations at this conference, as well as I expect more presentation in subsequent meetings so that we can actually understand exactly what happened with this study. Now, there is an interesting finding. I'll go back for a second there. There's an interesting finding from Odyssey is that the NT-proBNP went down reasonably well, despite the fact that our outcomes were as I showed you. And so it's just keep that in mind, because it's important to understand who tolerated the drug and who did not, and how did the patients who tolerated the treatment well do versus the patients who did not. And I don't think we have a clear answer yet for that. So in aficamten, we have Forest HCM, which is an open label, long-term extension study showing that over about 2 years of time, patients, small study, 34 patients that stayed on the drug. There were some temporary interruptions for LVEF less than 50%, or sorry, not interruptions, but there were temporary interruptions of the drug for EF less than 50%, but the patients had other things going on with them at the same time. And again, back to the story of looking at KCCQ, NYHA class, and biomarkers, which is what we use in our typical long-term extension and phase 2 studies. But in the phase 3 trial, which I should have here, this is the safety, which is patients, there were no permanent discontinuation in Forest over 2 years. And there were 4 patients with EF less than 50%. That's the range for you there. And only 1 patient had EF less than 50% corroborated by the core lab, as well as 2 of these were managed by down titration. And 1 patient was in the setting of AFib and the other was in the setting of an AFib procedure. So we just presented this last month at HFSA as well. And so that led, it wasn't Forest that led to the design of Acacia, but, as you would expect, aficamten is being investigated in non-obstructive HCM. I did not put ACC 2026 in there, so I don't know where that came from. Ignore that. I'm not so sure. I don't know actually when the study will be finished or presented there. We spoke before that it's going to be the first half of 2026.
No pressure, man.
You better go home and start writing, buddy.
No, but someone is going to take a screenshot of this and put it on Twitter. But this is not correct. So the ACC 2026. But anyway, and so aficamten versus placebo, 420 patients. However, the study was redesigned later on to have, different sample size and different outcomes there in terms of the peak VO2 and KCCQ change. And the study essentially is going to continue to run until the last patient finishes 36 weeks on the study, and it's one-to-one randomization. So if you have, do you have any comments? I actually wanted to ask your question about the NT-proBNP situation with Odyssey as it compares to the outcomes of peak VO2 and KCCQ that we've seen. That's one. And the second thing is that any insight into the placebo effect on KCCQ?
Yeah, great questions. You want to start?
No, you start.
I think, you know, with the biomarkers, we saw greater than 50% reduction in the MAVA group compared to placebo. And if you look at the curves quickly, it looks similar to what we saw in Explorer, where they divide pretty soon and they're sustained. We also saw decreases in wall thickness, changes in diastolic function, things that suggest to you that there is still a biologic signal for benefit with myosin inhibition, specifically mavacamten in this case, in those non-obstructive patients. But what we did in Odyssey is we enriched for folks that were sick, that had diastolic function, and we did that on the basis of the phase 2 MAVIC trial. And I do wonder if perhaps they were too sick or it took too long to show a benefit, or that maybe they weren't going to reach that threshold that we were aiming for, that we aimed too high in terms of a change in peak VO2, and that we're just not going to move the needle that much in a non-obstructive disease, right? This is a different disease, and it has a spectrum of contractility that's part of non-obstructive HCM. You have the folks that are hypercontractile, hyperdynamic, and look almost like an obstructed heart, but you also have the folks that aren't. And those that are even teetering on hypocontractility or have accumulated fibrosis. And I think it's a few diseases all in one bag, and that's probably not the way to approach non-obstructive HCM. We need to phenogroup them better, understand where to target them based on what their underlying primary pathophysiology is. And that's part of it. The KCCQ, wow. I mean, they're coming to clinic, you're taking care of them, you're adjusting their meds. So there's some Hawthorne effect there. But I found myself initially irked, and then I was like, well, wow, they got an increase of 10 points on their KCCQ just from coming to see us.
Yeah.
Like, I can't be mad about that.
No.
But it makes it awfully challenging to design a trial.
Yeah, I think disappointing for sure, because we had patients who felt better. And that was the part I couldn't remedy, right? And they were getting better, but when it came out, it just didn't play out. So 0.06, if I remember right, so wasn't way off the reservation, but it didn't meet statistical significance. So I think peak VO2 is difficult to rise as an endpoint. We all, as an HCM community, we need to rethink about whether or not that's an appropriate way to look at this non-obstructive group as an endpoint. ProBNP going down, KCCQ greater than 10 shows me a signal we may be on it. Maybe the doses were too high.
We also don't know how to dose in non-obstructive
That's what I mean.
HCM,
Maybe the
right?
doses were
When
too
we
high.
don't have a gradient,
So you do an EF.
you're going to maximally tolerated and sort of instead of minimally effective. It's like the opposite side of the story with Maple and going up on the beta blocker.
That's right.
Like, we didn't want to leave efficacy on the table. So we said, have at it.
Right.
But when do you stop? In clinical practice, you stop when your patient feels better, when their NT-pro is down, and you would be like, good, we're at a good spot here. But in a trial, it's not feasible. You're blinded.
Yeah.
You've got to go with the dosing regimen. And, you know, this is what you might get.
So I think stay tuned. We have a lot of patients in Acacia, so we're excited about what the outcomes is of that. So we're excited to see that come in, whether it's ACC 26 or some other time. I think it's important. This is another important study that's going to, I think, better educate us on how we should go moving forward, positive or negative. I think we're going to learn a lot about it, but we're obviously hopeful it works.
Fingers crossed for positive.
Agreed. And ultimately, you know, if you think about what 10 years ago, there were probably, like, you could just list the number of randomized multi-center clinical trials in HCM probably in like 2 seconds. Now you have many. We've spent the last 20, 30 minutes talking about this. So I'll turn it over to you, Anjali, I think.
We'll do a couple of cases. I think we each have one, and then hopefully there'll be some time for questions. Please, there's lots of questions. And alternatively, we could just do questions. Let's do a quick case, but I think there's probably going to be some good questions in here. So this is a woman, 74, HCM, paroxysmal AFib, hypertension, class 3 with a pretty respectable NT-proBNP for a patient with obstructive HCM, severely dilated left atrium, ejection fraction 65%. Here's her echo. She's on a little bit of metoprolol, 37.5, bradycardic, as you can see by her echo, resting heart rate in the 50s, so pretty well beta blocked, and with really high gradients, well above 100. She was fatigued, she had bradycardia, she did not want a myectomy, and her anatomy was not amenable to the alcohol ablation. As Ahmad pointed out, it's not up to you what your septal perforators are like when you were born, and she just wasn't a candidate. So she opted to start mavacamten at 5 milligrams at week 4. She was one of those folks that dropped her gradient a lot. So from over 100 down to 14 at RAS 23 with Valsalva. She felt immediately better and said, please take me off my beta blocker because it makes me tired. And we said, well, can we wait till we get through the titration? She was like, no, I want down. So we took it off or reduced it. And then on the next echoes, there was some sort of rebounding of the gradient, hadn't fully settled. And that's one thing to remember. Wait till you get to steady state on a drug before titrating, know its half-life, and wait. And so we eventually went up to 12, at 12 weeks to 10 milligrams, and she remained stable there. You can see week 16, week 24, nice low gradients, LVEF about 60%. She started in 65. And here's her echo. SAM is relieved, mitral regurgitation gone, gradients down to 8 from over 100. And her biomarkers were really remarkable. 2,600 down to 166. She felt much better. Left atrial volume index, way better. E over E prime, strain, everything better. She was able to come off her loop diuretic, which she was on as sort of a temporizing measure. Metoprolol was decreased. And we actually had to treat hypertension in her. And that's something that we see as you resolve LVOT obstruction, that some patients have hypertension because they're getting more blood flow, cardiac output out. But this opens up the avenue to use meds that you otherwise are not able to use in someone who's symptomatic and very obstructed. We're now using ARBs, we're using MRAs, we're using vasodilators and diuretics if needed.
So this is an opportunity because that's a question. So what's the optimal medical management for hypertension and HCM?
Oh,
Do you have a
beautiful.
go-to? Well done. You're clairvoyant.
So yeah, so if you're no longer obstructed, we use a lot of angiotensin receptor blockers. In some patients who still have a little bit of residual dyspnea or a little bit of a residual NT-proBNP, we do sometimes reach for an MRA, and those are our two drugs of choice. How about you?
I'm sorry, I was reading. What did you say?
Master,
I can answer that. So, I agree. My favorite is to go to an MRA. That's my go-to drug for hypertension in these patients, usually. So, we do lots of spironolactone. We recently have been doing more eplerenone, especially in men, because I don't know why, but we have a lot of problems with spironolactone in Portland. And so, so we do a lot of that. And so, and as you mentioned, vasodilators, you're no longer restricted in terms of the use of vasodilators. The most important piece is not to say that I'm using a beta blocker for the sake of anti-hypertension management or hypertension management. There is no reason to send someone on 200 of metoprolol just because you want to lower their blood pressure. That's absolutely not the reason to use this drug.
It's also not a good blood pressure lowering.
Yeah, exactly.
1,000%. So I use a lot of that as well. I also use a lot of valsartan based on the Vanquish data. So I'm going to answer a couple of these, this is just going to take a couple off your plate. The first is the question. This one question the guidelines, but based on MAPLE. When will there be a change in the current guidelines? So I'll take that. The answer is
as the guideline writer sitting amongst us.
No, there were others. I'm not the only guideline writer. I was one of the guideline writers. But you see, most of the time, there's lots of time between the guidelines. So from 2020 to 24 was the change in the HCM guidelines, which was the most rapid change we've ever seen. So we expect that in the next couple of year to two, that when there's new information that we ought to be able to reassemble the team and act more quickly so that the guidelines are not outdated and that we're not practicing in a way that the guidelines no longer reflect, meaning the guidelines may not be as helpful. So they ought to be more of a living document. So stay tuned. We don't know quite yet the the answer to that. I'm
Absolutely.
going to give that back to you, and I'll
Yep,
do the
you
second
do a
case.
case and I'll come up with another
I answered
question.
two of those, so I tried to get rid of them. So this is
So helpful.
a typical story, just like the last case, which is what we normally see. That's a usual response. We spend a lot of time digging into the times when it doesn't work, but most of the time we're seeing benefit from the CMI. Don't leave here thinking, boy, we're not sure if these work or not. They work, right? There's no doubt the CMIs are going to change the way it has already changed the way we manage folks. So this is another case we grapple with. A young woman, breathlessness, no chest pain, no syncope. Here's her ECG. A reminder, this should be burned into your memory. When you see T-wave inversions out through V4, V5, and V6, it is not an athlete. It is not normal. This is HCM until proven otherwise. Lots and lots of data showing that even if you echo them now and the echo is normal, over 40% in the coming 5 to 10 years will end up being HCM. So when you see this, don't think coronary disease, cath, oh, echo. Oh, we found apical HCM or septal HCM. When you see this, certainly if they have symptoms, we're thinking about ischemia, but HCM comes to mind. When we see that, we think HCM almost first. And as common as it is, that's important. And here was her echo. So I'm showing you a Doppler signal all the way to the left, a color signal in the middle, and then contrast in the prior to the ultrasound enhancing agents. So hopefully what you're seeing is that mid-systolic dropout where you've got flow and then a flow void where it becomes black there in the middle and then signal void and then flow afterwards. The color is showing you a mid-ventricular obstruction where there is kissing of the lateral wall and the septal wall, and then the contrast confirming there is indeed mid-ventricular obstruction with an apical aneurysm. So beyond the discussion about sudden death risk, because we know that's an important risk factor for sudden death, a 2A indication, my question to both of you is, what do you do? Based on these findings, is this obstructive HCM, apical aneurysm, amyloidosis? We already talked about how it is indeed an apical aneurysm. I'm trying to go forward. I don't think we need to answer it. If you can let me go forward. The question is, how do you treat it? I'm not sure if anyone's going to answer, but I do like the music.
They're going to answer. They're awake. They're answering. Drinking a little wine, they're going to answer.
Okay, so obstructive HCM was the dominant, apical aneurysm we mentioned. Any comments from the group?
I would add Fabry to the list. We've seen a few patients now with Fabry present with the mid-cavitary obstruction
Fair
of
enough.
apical aneurysm. So I think you have to first always understand what the underlying etiology of the hypertrophy is and then tackle the treatment. With the non-obstructive trials open and our mid-cavity patients being batched in that group, I've been enrolling them in trials. Now that there aren't any trials to put them in yet, I'm not sure.
Important to remember that you might think differently in like your practice, but for the sake of treatment, obstructive HCM refers to patients who have systolic anterior motion of the mitral valve with left ventricular outflow tract obstruction. That's what obstructive HCM is from a clinical trial perspective and from a cardiac myosin inhibitor perspective and from a myectomy perspective and from alcohol septal ablation perspective. Now, do you want to call this obstructive something, whatever you want to call it? I stopped using that term for these patients. I just say that there is mid-ventricular hypertrophy. There is essentially, there is acceleration of flow or velocity, whatever you want to call it, in the mid-septum, and there is maybe an apical aneurysm if you see one, or without an apical aneurysm. Because there is a lot of confusion where I have seen, and not always works out very well, where someone with this phenotype gets given good doses of this or good doses of that, and things don't always end up the way you would expect them to.
So that's what I wanted you to touch on. So thanks for taking the bait. So, because I think that was my point of this, that this isn't what we're talking about in the spirit of it. The label doesn't actually distinguish and write that out, so that gets mistaken. It's a nomenclature problem. Mid-cavitary obstruction, when you were explaining to a patient, they say, well, you just said I'm obstructive. Well, You're not obstructive in the spirit of what we normally think about with SAM, septal contact, and LVOT obstruction. This is a different mechanism, and I think at the present time, we have trouble treating them.
We should study them, right?
We-
And
we
they're
need a better
along
treatment.
that spectrum of disease that we talked about that's heterogeneous.
Yeah.
And it's not the one-size-fits-all bucket of LVOT obstruction.
And we
This
have
is different.
anecdotes where folks get better, but I have anecdotes where they don't get better. So I 100% underline twice, we need to make sure we study this group specifically and peel them out of Odyssey if we can find them as well as Acacia.
So here's another question. CMI use in real-world data is much lower compared to patients who would qualify based on LVOT gradients and symptoms. What do you think are the major barriers to uptake in CMI use?
I think every time you start with a new mechanism and new approach, it will take some time for adoption and adaptation to that. There is another reason is that I think it's now being perceived because of the RIMS program and because of everything that's going on, it's being perceived as difficult sometimes to do this if you don't really know how to do it. The lack of familiarity for a lot of physicians also with the drugs, and a lot of us have done clinical trials before the drugs became available on the market, such as mavacamten. So there is lack of familiarity. And then the last one, which is I think is the most important piece, is the disconnect between the physician perception and how well the patient is doing on metoprolol or on beta blockers and how actually the patient is doing. I think that's the biggest reason why patients are being undertreated.
I agree. Most of the patients say to me, is that the new drug? And I say, well, not that new anymore, right? We now have 20,000 folks that are on this in the United States. So I guess it's still new in terms compared to beta blocker, compared to calcium channel blocker. And I'll underscore what you said. There are a lot of resistance to say, well, they feel okay. I usually make them prove it. I put them on a treadmill and I make sure, talk to their significant other, just like aortic stenosis. Usually, you get the big eyes from behind the patient.
Yeah.
My doc, I feel great. They
Like,
feel great. Boy, we haven't been on a walk in 3 years. And then the reverse is true. When you make them feel better, I also have that result. I had a young woman who is in one of the AFI studies who said, I don't think I'm feeling it. And again, the husband's eyes got huge. And he was like, I said, do you have anything to add? And he's like, well, we went on a 9-mile walk this weekend. I feel like things are better, honey. And she was like, well, I guess that's true. So I think patients have trouble giving their symptoms. You got to pull it out, and it's on the clinician side to really ask them pointed questions, give them some things they can normalize compared to others.
All right, we have one last case.
We can spend less than a minute on this, though, I think. So this is an example of someone with obstructive HCM. You can see the SAM, you can see the LVOT obstruction, NYHA class 3 symptoms. But this is important because it relates to safety. So you really need to remember this, especially if you work in an environment where you don't have a lot of pharmacy support that can help you. This patient, essentially, the father died suddenly at the age of 42, struggled with depression for a long time, required many different regimens, and have been on fluoxetine for 5 years, and recently moved to the area and lives alone. And so that's an example of where you have to really be thoughtful about the concurrent medications that the patient are receiving and the circumstances. We have really a very quick, usually, reaction to saying, I'll just stop this, I'll just replace this. But in these scenarios, I think you need to talk to the patient and to their treating physician to make sure that you're not really changing a regimen that they really don't feel like they want to change. And so that's the case, an example of, alluding to, and this is a real case where this is one of my patients where, we wanted to put them on mavacamten, but we couldn't in an easy way because they were super resistant to anyone touching their depression regimen, because they've been struggling for a long time and they've been stable and steady. So that doesn't mean that you can't do that in your own patients, but you have to remember that you have to modify some of the other drugs if you want to use that. So refer to the label, refer to the different, drug-drug interaction resources that you use. But remember that, you need to talk to the patient. Don't be too paternalistic about this. Talk to the patient and see what's going on with them as well.
Yeah, so I think the REMS data speaks to this as well. Certainly challenges with the REMS data, but it's the largest group of patients we have to look at. And it shows us what's happening in real life in terms of drops in ejection fraction. And it tells us what's happening with drug-drug interactions. And they're relatively low. under 1% or so. However, most of us are in clinical practice are changing the medicines ahead of time. And I agree with you, it requires a phone call. If it's a chemotherapy, if it's a chronic therapy for rheum, if it's an antidepressant, it requires you to make a phone call. So in our practice, there's some flexibility to do that. But for me, it underscores why this should really be biased, that we should be working together with folks who don't use this a lot, and we can initiate the therapy, offer the different options, talk to the patient about how to do it, make sure that you cover all of this, and then partner back with the individual who sent them to me and get them back to them to continue the therapy as an outlying cardiologist with you. But I think there's benefit in having these early discussions and offering different options so that it isn't given as a willy-nilly, that there's some discussion with this to make sure we avoid those complications.
Couple last questions. We have about 4 minutes left. So there's a couple of questions regarding the effect of CMIs on malignant ventricular arrhythmias, need for an ICD, thoughts about LVOT obstruction being historically thought to drive VT and sudden cardiac death, the 5-year sudden cardiac death risk calculator, including LVOT gradient. What are thoughts in that general vicinity? Sudden cardiac death risk, using gradient as one of the factors. Will that change with CMI?
So at least at present, it's not part of the current ACC/AHA guidelines from 2020 and 24. It fell off compared to 2011 to 2020. The European section still keeps that LVOT gradient in there. And if you go back and look at that data, it was missing some of the more traditional things we do now, like scar burden, like LV dysfunction and apical aneurysm. So that's why it wasn't as robust to fall off. So at least at present, my answer would be, we don't know yet if it improves sudden death risk by removing the LVOT obstruction. More work's got to be done along with the fibrosis to see if we can prevent it from happening. At least at present, there's no indication to use this, whether the wall thickness gets thinner or not, to use to eliminate risk for sudden death. I think that discussion happens up front, just like it happens before myectomy.
And the LVOT gradient is a surrogate for the severity of the disease. The highest gradients I see are 85-year-old women with tiny LVs.
Right. So by definition, they're safe.
And they're safe, and they never die suddenly, even though they have had high gradients for a long time. So I think high gradients for the younger population are just a surrogate for the severity of the disease.
Agreed. If you look at as you say, left atrial size, and a lot of them are giant left atrium associated with non-obstructive HCM, suggesting that the LVOT doesn't have any role in this. So part of the reason that's why it fell off.
One last question. It's a good one. May generate some more discussion. We only have 2 minutes left. Is there some selection bias in MAPLE if you are including patients who have been on beta blocker therapy previously and continue to be obstructive? Also, MAPLE showed around 25% complete responders in the metoprolol arm. Do you feel like that reflects real practice?
Feels like I have to give this to you first. Since you
No, I can just tackle the first one. Is that this was pre-specified as part of the trial, that you're going to look at naive patients versus naive patients who were on metoprolol before, and there was really no heterogeneity there in the outcome. And the results were so consistent that if you look at that table with the forest plot, everything is on top of everything else. It's absolutely nothing to report. Everything was in the same line of things. And I don't think if you've ever let's imagine MAPLE did not exist and we were talking about metoprolol or beta blockers. Does anyone really think that there is long-term effects of metoprolol, for example, that when you take it away and when you start it, that does make a change? Does anyone really think that a short period of washout is gonna introduce selection bias, that only patients who want to wash out will be there? I can tell you, as a high enroller in the study, we've never approached this. We just offered it to every patient. But you had to start somewhere because
I think that's key.
People felt beta blockers are beneficial. Right. So you had to start somewhere.
So I think that's the key, is that this reflects what's happening in clinical practice, right? You can't fault folks for enrolling people who are on beta blockers because that's what the guidelines tell us to do. So you can't fault that. It is a place to start. I don't know that it's the end of that discussion. I always joke, don't sell your beta blocker stock just yet for any of you that are high stock purchasers for beta blocker. None of you, I hope.
Now he's
but
going to give financial advice. It's time to cut this off.
How much more
Dr.
wine can
Martinez
we
is
get?
giving financial advice.
But I think it's a place to start, and I think there's more to come on this story. But I think it's the first, and you'll see more of this retrospective data. There's a poster on Monday that shows more of this discussion. So I think, as you say, really important place to start.
And take home point, do the trials. We need them. Thank you so much for your attention, and thanks to both of you for joining me tonight.
Thank you. Thanks for
Take
coming,
care.
everybody.